Thanks, Ashvin. That's an interesting topic you gave me, and I had to think about this for a minute. What would be unique about this? So, I mean, the bottom line with these premium IOLs is we have to be within a half diopter of target, ideally. This was shown in a paper by Hayashi, where induction of a half diopter of astigmatism or the Restore 3 diopter dropped the distance vision by almost a line and a half. So, what do we do? Some of this is obvious. Get two, preferably even 3 measurements. Here's a patient who's got 2.48 diopters of astigmatism that you can see there, but he's got an abnormal mire and with a regular LED reflection. The lens star for this patient gave a much different value, and what I did is remeasure this patient, treated the surface, and got 2 measurements that were the same, and then we knew that we're in good shape. Really critical, obviously, for your premium IOLs. So we like to measure 3 times and at least on 2 different days. And we use different devices. We use 2 biometers, and we use a tomographer topography device, the Galilei. So I have also have the advantage of seeing placido mires, and it makes a big difference in the repeatability and the accuracy of our measurements. And you really have to verify the quality of your measurements. Obviously, optimizing the ocular surface is important. We ask all of our patients before we measure them to use tears, warm compresses, and lid scrubs, and that's really helped our accuracy as well. You want to not miss subtle corneal pathology, and it is easy. Some of it's going to be obvious, EBMD or Salzmann's, but here's a patient who had a trifocal, complained of poor quality of vision, and you can see he only corrects to 20/50. And you can see the topography is kind of funny looking there. And then if you look at the mires, which is again why I like having a placido image, you can see the irregular mires below. And this patient had a very subtle subepithelial scar that was distorting the vision. And I did an IOL exchange and put in an IOL that was a monofocal with 0 spherical aberration and was able to get his vision to 20/25. Use the latest formulas. There are a lot of formulas using geometric optics, ray tracing, artificial intelligence, hybrid formulas, although really almost all of our formulas now have some element of big data, maybe even artificial intelligence, but they're good formula. The newer formulas are clearly superior. So use the newest formulas. And what are they? Well, they're highlighted here: the Barrett, the Castrop, Koch, Holiday, the 2 ray tracing, the Hill RBF, and several of the hybrids. Now, you're not going to use every one of them, but pick 2, or at least 1, or maybe 2, and use those in your patients. Well, what kind of accuracy can we really expect to get? If you look at what we've published and others, the patients really fall into 2 categories: normal eyes and long eyes. I think you can hit 90% within a half diopter of target. But short eyes and post-refractive, you're looking at 70%, and that's something you really have to share with your patients. One other thing, don't overcorrect with the rule of astigmatism, and don't undercorrect against the rule of astigmatism. Look at your toric calculation, even if you're not thinking you really need a toric lens. So here's a patient, this is using Veracity. This is not a multifocal, but it makes the point about astigmatism. He wanted mini monovision, some intermediate. You can see his K readings. He's got about 0.3 at 0.4 at 30 degrees, and you think, this guy doesn't need a toric. And then you kind of look at what the predicted refraction is, and it's 0.68 diopters at 10 degrees. So that's actually not acceptable. So if you look at what happens when you program in a toric, a 1 diopter toric, this would leave the patient with 0.3 diopters at 100 degrees. So that's what I did. And he ended up with a half diopter at 75, which is nice because what's going to happen? That's going to degrade or diminish over time as it goes against the rule. And the final point I want to make is know what the defocus curve is of your IOL, of your premium IOL, and use it to your advantage. For example, here's the defocus curve for the Synergy lens. It's a very steep peak, and these patients do better actually if you target a little bit on the plus side, maybe a 1/4 diopter hyperopic, because a 1/4 diopter hyperopic in your lane is actually plano at distance. So that's the lens and same with the Panoptics. We found that you really want to target a little bit on the plus side. On the other hand, there are IOLs that have a larger landing zone. This is the Odyssey lens. And if you target, because it has such a big landing zone, if you target minus 0.3 diopters, you're going to get better near vision and yet still get 20/20 distance vision. So, in summary, get lots of measurements, preferably on different days. Don't miss pathology, even though it might be subtle. And despite your best efforts, you're going to obviously expect to have misses. They're going to require corneal refractive surgery or lens exchange. Thanks very much.
Doc, excellent talk as always. Now, we know you are the IOL calculation guru, so I will take advantage of this to ask you a few questions, if you don't mind. First of all, what I'm always puzzled with when I do the toric IOL, and I put in different formulas, I get most of the time different axes where to put my toric alignment in. So I want you to comment on that, and what is the influence of surgically induced astigmatism on those calculations, and do you need to put it into your formulas, the surgically induced astigmatism? Because when you work on a temporal side, you induce like 0.08 to 0.12 diopters of astigmatism, and in those low diopter, low astigmatism corrections, it can mess up your calculation. So I would love your input or insights on that.
Great questions. You know, with Veracity, we have three formulas: the Abulafia Koch, the Barrett, and the Kane, and they're very close to one another. They're remarkably uniform, so that makes my life easy. They rarely vary by more than 2 or 3 degrees rather, and very rarely do they vary in the power. So I just rely on those. Those are the ones I'm used to. As far as SIA, surgically induced astigmatism, I think you're right. It's going to be about 0.1 or less, and yes, it'll affect things when you're correcting small amounts of astigmatism. But you know, I kind of try to almost factor it out and ignore it and rely on the formula. But the formulas that I have are programmed with my 0.1 diopter, so that helps me. I think one of the things you see when you start to look at this more, for example, that patient who had astigmatism at like 30 degrees, it said to put the toric at 10. And that's because the formulas have accounted for the fact there's some tilt and other factors that fit into it. So there's this kind of conundrum about, well, the cornea is here, but it's telling me to put the IOL there. We've learned to trust the formulas.
Thank you.
All right, thank you.
Doug has to go, so if anybody has a question, you can ask him.